All right, BE routines. So you are usually either going to do a single BE or a double BE. And for our clinical site, these are our routines. So single BE, your radiologist might ask for a PA and an AP, routinely just an AP. If they want a sigmoid, they're going to do an AP axial sigmoid. For single BE, you're going to do 2 obliques. Most often, they're the posterior obliques, but we'll talk about the anterior too, just in case. A lateral rectum, and then sometimes just a post-evac. Your radiologist may ask for one of these. They may ask for none. But if they just leave the room and tell you to do the routine, you have to know the routine. So these are some specialty views that I don't think you'll see at the clinical site, but they might be on your board, so we're going to cover them as well. Double. Remember, double BE means air. So you might do just an AP, or they might want an AP and a PA. The axial sigmoid is the same. With double BE air, you're going to do a right and left to cube instead of obliques. So air to cube. Remember, the cubes are to see that air fluid level. And then a cross table lateral rectum instead of just a lateral rectum recumbent. You're going to shoot cross table, so the patient's going to be prone. Again, air fluid levels. AP post-evac. And upright is rare. We haven't done one in years, but you know, there's always a chance, so be prepared, okay? So technical factors, just a reminder for BE overhead. So if you're using barium, we use 110 kVp. It might be 109 in the room. A real large patient, they might increase to 117 or even 120. But just keep in mind your 15% rule. So if you're using 110 kVp, you want to decrease your MAS by half. And I'm talking about sort of your original KUB technique. So I always look at my patient when they come in and think, what would I use on their KUB with no contrast? Are they a 20? Are they a 25, a 32, a 40? Do you have a really large patient? So find that out first. Keep it in your head. A double enema with air or water-soluble contrast, we tend to use between 80 and 90 kV. So not as much of an increase, but not quite the 110. But you are still going to decrease your MAS, okay? Scout. I always ask my radiologist, I bring them all my paperwork, and I say, would you like a scout KUB before starting? Some will say yes, some will say no. But you better ask first before they put contrast in. Then they turn around and say, hey, did you do a scout? And I'm like, nope. So mark it scout, annotate. Remember annotate? Right on your image, put scout on there. All right, single enema routine. You're either going to do a PA and an AP, or just an AP, or just a PA, depending on what they want. Most often, it's just an AP. If you can do a KUB, you can do barium enema views, right? So it's just like a KUB, almost exactly the same. If they are the size of this lovely lady right here, you're going to do one lengthwise, center to crest. If you would do 2 crosswise on their KUB, you do 2 crosswise on this. All right, overlapping, make sure you overlap. If they need quadrants, you do quadrants. It's going to take quite a long time, but you do it anyway, okay? So run it exactly as you would for your KUB, okay? What do you want to see on an AP or PA? You want to see all of the large intestine, right? So ideally you want to see from the top of this flexure, this left one is always higher, right? You want to see the top of this flexure all the way down through the rectum. The transverse colon is going to be filled with barium if they're prone, because remember the transverse colon sits anterior. So really similar to that as the stomach. The stomach fundus sits posterior. Transverse colon is anterior. This will come into play in a little bit when we talk about the double enema and where's the barium and where's the air sit. All right. This was just a nice anatomy picture here that I liked. All right, you're going to do, after you do your PA or AP, you're going to do 2 obliques. And most often we do an LPO and an RPO. So it's 35 to 45 degree obliques, almost exactly the same as your oblique L-spines, looking for those Scotty dogs, really similar, okay? So 35 to 45 degrees. You're going to center to iliac crest and 1 inch lateral to elevated side, all right? And on the obliques, we're looking for flexures. That's our focus. So LPO looks at the right colic flexure. Okay, so LPO is for the right, RPO is for the left colic flexure. So it's opposite. So R looks at L looks at R for the posterior obliques. Okay, keep that in mind. So RPO, right? Another image here. Make sure they're up, make sure they roll like a log, similar to that of your lumbar spine Scotty dogs. LPO, okay, same thing. You guys will use a sponge underneath your patient, hopefully to hold them up. This young man's doing it all by himself. Alternate, prone obliques. You most likely will not do this in clinical practice, but the boards love to ask about these alternate obliques, right? So LAO and RAO. It's the same degree of oblique, 35 to 45, iliac crest, and 1 inch to the left of mid-sagittal plane, okay? RAO looks at the right. So if you remember, RAO, right, always open. The anterior obliques look at same side. Posterior obliques look at opposite side. So PO, if you go POOP, posterior oblique looks at opposite. Anterior oblique, always open. So right, always open, RAO. LAO, left, always open. So LAO looks at the left flexure. Okay, so anterior is the same side, posterior opposite, POOP, okay? AP axial and AP axial oblique. We call this an angled sigmoid or your sigmoid shot. Most often, the patient is supine and you simply angle your tube 30 to 40 degrees cephalad. We did have a radiologist who used to ask us for an angle shot, and that's what he meant. The patient is in LPO, and you do the same angle. I haven't seen that in many years, but it's in your book, so we'll review it. You're going to center 2 inches inferior to ASIS. So AP axial, 30 to 40 degrees cephalad, 2 inches inferior to ASIS. This is looking at your sigmoid, so keep that sigmoid in mind when you're doing this angle. One of the things, and I'll go over it at the end here, is the reverse of this. So if the patient is prone for this, you're going to angle down. So if they're laying supine, toes up, angle up. If they're prone, toes down, angle down. So when they're prone, just reverse this angle, okay? This is what your sigmoid will look like. It elongates the sigmoid, just opens it up, okay? It's also sometimes called the butterfly view. All right, lateral rectum. If you can do a lateral L5S1 or a lateral sacrum coccyx, you can certainly do a lateral rectum. So a lateral sacrum coccyx, right, you can see the sacrum here in this image. So we're just looking at the rectum. So come down from your spot and get that on, okay? Patient in true lateral, it can be left or right. Left is easier for us in our rooms. You're going to center the level of ASIS in mid-axillary plane, 10 by 12. Okay, you're looking at the recto-sigmoid region, all right? That's where we want to look. So sigmoid, rectum here, and this is the tip in place. And that's it for single BE. I'll meet you back here for double.